All right. I've got a bit of a scratchy throat today, so if I'm unintelligible, raise your hands, okay? Thank you for having me here. I'm very pleased to come and talk to this group about heart failure. A lot of you probably wonder what's a geriatrician doing talking about heart failure. And in fact, I was introduced to this not by a cardiologist, but by a geriatrician, Dr. Turpey, and we would be going to long-term care facilities and retirement homes to see cognitive issues and frailty and functional decline. And half of the patients had unrecognized heart disease as part of the central manifestation of their geriatric syndrome. So that's really why I got involved in this. So we're going to talk a little bit about some of the epidemiology, but focus mainly on heart failure and how it manifests itself in older, frail people. We're going to talk about heart failure management, which has been done mainly in the outpatients, and what is not being done in long-term care, and how hopefully we can come about to change things for the better for the patients. So, very briefly, and there's a lot of studies that look like this, but just like dementia, heart failure is a disease of an aging population. So as you hit 55 and you keep getting older, the risks of having heart failure start to come up very quickly. And in fact, if you live to be 80 years old, you've got about a 20% chance of developing heart failure before you die. So it's almost as common as dementia. Obviously, it's a lethal disorder in many cases, especially for seniors and especially for frail, complex seniors with dementia and other issues. So this is Ontario data. So all comers, first hospitalization, 1-year mortality, 33%. And if you are older, if you are demented, if you have multiple medical problems, the mortality rises to 60%. So it's a fairly lethal disorder that tends to pick off the frailest. But the big issue in terms of the system is the morbidity that comes with it. So it is one of the most common causes of hospitalization for people over 65. And Dr. Bell's, one of his interests is in transitions of care, which is very important for heart failure because the readmission rates are really high. So up to 23 to 50% after 3 months after a discharge from hospital, readmission rates are up to 50%. And again, this disproportionately affects people who are the oldest old. So most of the hospital days are for patients with heart failure over the age of 75. Now, we don't have Canadian data for heart failure specifically, but the U.S. data is now over $30 billion per year, so you can divide by 10. That's the cost to acute care from heart failure in Canada. So what about long-term care? Because that's why we're here. It's very common, and in some of the studies, up to 45% of people have heart failure. And this 45% comes from a study where you had a geriatric cardiologist go and assess everyone individually clinically. And they came up with this figure of 45%. 1-year mortality of these folks is over 40%, but if you happen to have a heart failure exacerbation in long-term care that requires hospitalization, you have about 4 months to live. So it's often one of the terminal events. And in terms of healthcare utilization, it's responsible for 1 in 7, 1 in 6 transfers of long-term care patients to acute care. And again, if you think of what happens to these folks, 90% go through the ER. Their mean length of stay is 6 days, and despite coming from a nursing home, a fair number of them end up as ALC patients again. They get sick, they lose their bed, they're stuck in hospital. So why is this more of a concern in seniors? Why is this important in long-term care? Well, there's a couple of issues. So heart failure in older folks, a couple of geriatric syndromes that go hand in hand. One's cognitive impairment. We think of them as separate diseases, but in fact, if you have a history of heart failure, you're up to 80% more likely to have cognitive impairment. In hospital, many of these folks come into hospital and they suffer an acute delirium in over 50%. But, and this is the interesting bit, in the community, and these are prospective studies with 5-year follow-up, having a history of heart failure increases your likelihood of developing Alzheimer's disease, not just vascular dementia, but Alzheimer's disease by 80%. That's important because we all know that heart failure, we have very good therapies for it. Even in nursing homes, we have therapies that are useful, but these folks forget to take their pills. They don't recognize when they get sick. They don't listen to the dietary advice. They don't exercise. They see their ankles swelling. They don't know what to do about it. Cognitive impairment in heart failure interferes with their ability to self-care. And as a result, we see increased rehospitalizations, we also see further functional decline, and we see higher mortality in heart failure patients with cognitive impairment. Frailty. Again, we think of frailty as an age-associated thing, but there's an interaction there too. And the best data we have comes from a very large study in the States, the cardiovascular health study, where they followed almost 5,000 community-dwelling seniors, on average at the inception are close to 73 years old. And these guys did every single measurement you can imagine on these folks related to the heart and related to frailty. They did cognition, they did frailty scores, and they did everything else. And the people who were the most likely to become frail over the follow-up period were those with heart failure. And it increases your risk by 7.5 times. What do you see in a hospital with someone who gets hospitalized with heart failure? Well, this is a study that looked at ADLs. And ADLs before hospitalization, ADLs during hospitalizations, and ADLs after. And on this scale, the higher the number, the worse your function is. So what you see is they come into hospital, and obviously they decline. That's not unexpected. After discharge, they get better, but they never make it back to baseline. And this was a clinically significant difference. They needed more home care. And if you can look back to that figure of all the readmission rates, you can imagine how an older person gets readmitted multiple times, and every time they lose ground. And where do they end up? They end up in long-term care. The other interesting thing about all this, which makes heart failure so much more interesting to manage and difficult, is that frail people tend not to come to you and say, I'm short of breath on exertion, or I have orthopnea. They come to the emerge confused, they come to the emerge falling, and they come to the emerge incontinent. A senior who is frail tends to present atypically. And this is one study that looked at that from Halifax, and the interesting thing was the diagnoses were basically one of three: cardiac, mainly heart failure, infection, or a metabolic problem, sugar, oxygen, glucose, something like that. Easy causes to recognize if you think about it. So, I know we don't have too much time today, but how do you manage heart failure? And I want to talk a little bit, I'm not going to go through the whole guidelines, that's really big. But basically, the guidelines will recommend that for most seniors, most of the recommended therapies are applicable. Now, you have to be a little careful depending on concomitant issues, but we can talk a little bit more about that. But, and this is particularly so for ACE inhibitors, we have a fair amount of observational and even some small randomized control trials that show that ACE inhibitors are also beneficial in frail seniors, even in long-term care. They improve function, they reduce the rate of cognitive decline, they can improve cognition, and there's even some evidence that they might improve mood as well. So again, I won't harp on that, but just to point out that there is a website, the Canadian Cardiovascular Society has all the heart failure guidelines, and there's lots of educational toolkits in there. But again, the core therapies, the ACE inhibitors, beta blockers, that's why I'm putting that up there, are generally tolerated even in your frailest seniors. And here's some of that data on ACE inhibitors, again, in frail seniors. Fewer deaths and hospitalizations, even in people who have chronic renal failure. Mild to moderate renal failure is not a contraindication, and they tend to do better with ACE inhibitors. Slower functional decline compared to other drugs such as digoxin. Greater cognitive improvement that's improved. So the higher the dose they get to, the better they get. And there's PET scan imaging studies that show that as well. You should look at their brains before the ACE inhibitor and after the ACE inhibitor, and it just lights up. It perfuses. Even if the blood pressure is low, their brain gets perfused. They get greater improvements in physical function, and that's from a randomized trial in a day hospital. So these folks were 80 years old, ACE inhibitor naive, with walkers, randomized to an ACE inhibitor versus placebo, and at 10 weeks they were walking 137 meters farther. And again, we talked about the other potential benefits on mood, on sleep, possibly psychosis, nocturnal urinary issues as well. Beta blockers, some evidence not really related to those geriatric syndromes, but we do have randomized trials, fairly older folks, and some good observational studies. And the bottom line is they tend to be good at reducing hospitalizations, which is probably a good thing if you're an older person. You don't want to go to hospital. So again, that's not a bad thing, but we'd like to have more data on geriatric outcomes, obviously.